Good morning, everybody. First of all, thank you very much for the invitation. It's really a great honor for me to be here in Campinas. I would like to present what's new on male slings. So, as you all know, the main causative factor for male stress incontinence is the radical prostatectomy or the urologist. So the persistent post-prostatectomy stress incontinence rate is between 10 and 20%. In some very high experience centers, they reach 5% or lower. Today we have several surgical treatment options available. Of course, the artificial sphincter, several types of sling bulking agents, and still the balloons. So if we talk about post-prostatectomy incontinence, I would like to share some very important facts about post-prostatectomy incontinence. Especially after radical prostatectomy, patients very often tell you that they are continent if they are coughing. What is the reason? The majority of the patient is continent during really quick and short increase of pressure. This means the striated sphincter parts are intact. There's only a problem with the smooth muscle parts. So the smooth muscle is important for the basis continence. So if the striated sphincter parts are exhausted, the patients experience stress incontinence. So the artificial sphincter, of course, is the established treatment for moderate and severe post-prostatectomy incontinence. We have really good continence rate with a social continence rate of about 80%, but the artificial sphincter is associated with high surgical revision rates, and the patients need some dexterity and sufficient mental status to handle the artificial sphincter. And if you ask your patients what they prefer, an artificial sphincter or a sling, they want to have a male sling. What is the reason? It's no mechanical device. It's very easy to handle. We don't have anything to handle, no pump or anything. It allows physical voiding. It is sometimes a smaller implant, it's less invasive, and the patient has no post-operative deactivation period. If we look at all these male sling types, they are available. We have adjustable compressive slings, like the Argus or the Argus T or the new Phobos, the Atoms, the Remix, and we have fixed slings. And in fixed slings, we have two types. It's the retrouterus sling and the fixed compressive slings. If we discuss about the different types of male slings, we have to look at the mode of action of the different slings. So the mode of action of the retrouterus slings is multifactorial. We have a post-operative hypermobility of the ureter, and these type of slings correct this hypermobility. It increases the length of the functional ureter, and in addition has a venous sealing effect. So the advanced sling, or the second generation, the advanced XP sling, is the most common retrouterus sling. I'm not really sure if you have here in Brazil the Advance or the Advance XP. The Advance XP was launched in Europe 2010. What do you have here? Advance or Advance? Advance. So the Advance XP, you can also have the XP. No, the Advance. So the Advance XP have some changes. I will show it to you. And unfortunately, the Advance XP has no FDA approval. This is the reason why it's not available in the US or in other countries. Maybe this is the reason why it's not available here in Brazil. If you look at the outcome, we have a cure rate of up to 70%, and there's no difference in outcome of the advanced and the advanced XP. It's really comparable. The only difference is that in some cases you have a loosening of the sling in the early post-op period, normally within the first 3 months. And due to the special anchor mechanism in the advanced XP, you don't have it in the advanced XP. The complications are really rare in the advanced or in the advanced XP. The main complication is temporary residual urine or retention, pain problems, infections, like you have it in other sling systems, are really, really rare. I would like to say the only problem with the advanced XP is an overtensioning. And this ends up with a persistent residual urine. And the only chance to solve the problem is to cut the sling arms. I recommend only to cut one sling arms after 3 months if you have the overtensioning problem, because if you cut both sling arms, the patient will be incontinent again. If you wait for 3 months and cut only one sling arm, the patient has a really high chance to stay continent. And this is the reason for the overtensioning. You see here this elastic sheet. This elastic sheet protects these anchors during the implantation. But if you try to pull it out, you sometimes have really, really pull hard, and in this moment you can cause an overtension. And due to these anchors, it is really fixed. In addition, there's this Dynamesh PMR. The mode of action is really similar to the advanced. The implantation technique is similar to the advanced. You see it looks a little bit different, and you can compare it a little bit with the advanced, not with the advanced XP. Unfortunately, there's no studies published at the moment, so but probably the data are really comparable with the advanced sling. If you look at the fixed compressive sling systems, you have the Virtu, the iStop Toms, the Ethicon, compressive inside-out transobturator sling. The mode of action in these slings is completely different. You have a ureteral compression with subsequent permanent increase of the ureteral resistance and angulation. If you implant the sling, you position the sling on the bulbous spongiosum muscle, not directly on the bulb like you do it with the retroureteral slings. So I would like to show you quickly the results. Here you see the Virtu sling. It's a fixed forearm sling. You have 2 transobturator arms and 2 precubic arms here for better fixation. The outcome is not really so promising. If you look at the good data with a new fixation of the sling, you have a cure rate of 46% of the patient. And with the iStop Toms, it's also fixed forearm sling, also transobturatoric approach. You have also a cure rate of 47 up to 50% of the patient. If you have now a look at the adjustable slings, and especially of the mode of action is completely different. We have a permanent increase of the ureteral resistance, and it is recommended to increase it only for 2 to 15 centimeter water to support the basis continence. And 2 to 15 centimeter water is enough for continence, and the risk for erosion is with this pressure very, very low. In the beginning, we started with 40 to 50 centimeter water, and in these patients, we saw a lot of pain, and we saw compression, obstruction, and erosion. So 10 to 50 centimeter water is enough. The outcome of the adjustable slings, the Argus or Argus T, the atoms or the remix, are really comparable. It's really easy. The outcome is comparable. It's important to know with these adjustable slings, there's no difference in the outcome in patient with and without radiotherapy. It is a completely different story with the fixed slings, the non-adjustable slings. There you have lower success rate in irradiated patients. So you have in the adjustable slings, unfortunately, some important complication like pain, and persistent pain can occur in up to 5% of the patient. And also infection and erosion is higher. The good thing is you can adjust all these sling types and then adjust it to the personal physical things the patient is doing. I already showed you the results of the Argus, Argus T, the atoms, and the remix. These slings are really old or older, and the newest adjustable sling is the forward sling. It's the next generation of the Argus. It's only a single incision. It's implanted also via transobturator approach. It has an extendable needle to connect really easily the slings arms when doing the implantation, and has a scrotal port like the atoms, because with the Argus or Argus T, always incision was necessary for adjustment. Unfortunately, also there is no published data available at the moment. So now the important question is every sling type the perfect one for every patient? So this is our cancer neck. No, it is not. How can I choose now the perfect sling for my individual patient? I can have a look at the continence rate and complications. Surgeon preference is important, or I can do a patient selection. If I only look at the adjustable systems, the outcome, the complication, and the surgeon's preference is important. Then you can choose whatever you want to. If you want to compare adjustable slings and fixed slings and choose the perfect one for your patient, then you have to do a patient selection. For patient selection, one examination is very important. It's a ureteroscopy to check the sphincter function and do the so-called repositioning test, because for the fixed slings, you need really a good residual sphincter function to have the best results. I'm not sure if you know the repositioning test, or if everybody of you know the repositioning test. This is why I would like to explain it to you. You use a cystoscope, you put it distally of the sphincter. This is the first picture here. Then you put some mild mid-perineal pressure parallel to the anal canal below the bulbar ureter for the repositioning of the ureter. You see it here. You can use a sponge or you can use your fingers. And if the test is positive, the sphincter closes autonomously, concentric and complete, like you see it here. The patient is completely relaxed. I close the sphincter only by repositioning of the posterior ureter. And now, if I ask now my patient to contract the sphincter, the cooperative zone or the functional sphincter length closes. And this cooperative zone should be at least 1 centimeter. And you can see it here. And here always at the same point in the ureter. See it here, the sphincter open. See it here, the sphincter closed. And all this here is closed in this picture. And this is the ideal patient for fixed sling. So I have a video for you. This is only the repositioning by my fingers. And now I ask the patient to contract the sphincter. And now you see the sphincter length, it's at least 1 centimeter. This is the so-called cooperative zone. Once again, and if you hold the cystoscope really soft, then the patient really pushes you out. You can really feel that the sphincter and the functional sphincter closes. I have some pictures of negative repositioning tests. This is a patient after radical prostatectomy, radiotherapy, and resection of the anastomosis. You already see here that there's some sphincter defect. I'm able to close the sphincter, but not completely. If the patients contract the sphincter, it closes, but the functional sphincter length is really short. In the beginning, we implanted in these patients ortho-fixed slings. But I can tell you what happens in all these patients. They will end up with an artificial sphincter because they are still incontinent after implantation. They have a really high chance that the fixed sling will not cure their incontinence. And it's the same after TOP. This is a patient after TOP. You already see here some sphincter defect. If I reposition it, you see it really clearly, the sphincter defect. The patient is able to close the sphincter, but the sphincter, the functional sphincter length is really short. There's nothing. So also this patient had an advanced sling in the beginning, but today I never would do it again in a patient like this. So today we know there are some preconditions for success. For the fixed slings, you should only use it in post-prostatectomy incontinence grade 1 and 2, not in patients with nocturnal incontinence, only in patients with a long functional sphincter of at least 1 centimeter with a mobile posterior ureter without radiotherapy. And we know the risk factors for failure. These are weak sphincter function, incomplete sphincter closure, sphincter defect, and grade 3 incontinence. This means nocturnal incontinence. The adjustable slings are good in all the other patients, but they need a residual sphincter function. If the patient is complete incontinent, the adjustable slings will not have a good success rate. So patients should be able to store some urine. Not everything of the urine if they go to the bathroom, but they need to store the urine. So this is why we recommend today an individual patient treatment and not to put in one type of sling in every patient. So for an individual patient treatment, I listed you all the preconditions for success and the ideal patients for the different types, including the artificial sphincter, because yes, still today we need the artificial sphincter, and the fixed slings and the adjustable slings are very good, but not in all patients. So in conclusion, we have several sling types today available. The mode of action of the different slings types are different, and this is why a patient selection is mandatory, and the individual patient treatment is necessary to have the best results. Thank you very much. This is a picture from me. And to be honest, if I look out of the windows of the hospital, I can see the Alps.
Thank you very much, Professor Bauer. I believe I have some question.
Could you tell me about your personal experience with the Forbus?
So, my personal experience with the Forbus is that the implantation the technique is very easy. The results are comparable to the other adjustable slings, but at the moment we are evaluating the second generation. I don't know if you know the reason. The reason is that the first generation had a leakage like it was in the atoms in the very early beginning. With the atoms they had a leakage, and with the fibers they had a leakage as well. So at the moment we are testing the second generation. It looks like that the problem is solved now. There's no leakage any longer. The results are comparable to the other adjustable slings. However, if I used before the Argus or Argus T, and the adjustment is so easy now. Before, the patient has to come in the hospital, they had to stay for 3 days in Germany for the adjustment. They needed general anesthesia, and this was not very comfortable for the patient and also for me. And in addition, the implant now is quite smaller, and if you compare it, for example, to the atoms, this is what I really love, because the huge cushion of the atoms causes really pain.
So now you can inflate the device under local anesthesia in an outpatient basis?
Yeah, via a scrotal port.
Okay.
It takes me 1 minute.
Thank you.
And this is very comfortable for the patient.
In your experience, what is the better procedure for the patient after radiotherapy?
It depends of the grade of the incontinence. If the patient is still able to store some urine, the adjustable slings are really, really good in these patients. I recommend never to use a fixed sling because the results are really bad. But with the fixed sling, with the adjustable slings, you have really good results. And especially in Germany, we have a lot of men, they refuse the artificial sphincter. And it's a very, very good opportunity and that we can offer these patients.
You
don't talk about performing urodynamics before the male sling. Don't you perform? And I'm afraid about two results. Under acute bladder could give bad results to the sling, and the trasoid activity. What do you think about?
So we don't perform it on a regular basis on every patient, but every patient who had a radiotherapy has some neurogenic disorders, including diabetes, has some frequency, urgency, or already had before the prostate surgery some storage problem, we perform the urodynamics, yes. But if the history of the patient is really clear, loses only urine doing physical activity, going to the bathroom every 3 to 4 hours, have no urgency, we don't do it. Had no additional radiotherapy, we don't do it. We did it in the beginning, but it had no impact on the decision we made finally. And in Germany, the patient had to wait 4 to 12 weeks for urodynamic evaluation. So this is why you have to select the perfect patient for the evaluation.
Ricarda, some papers emphasize long-term results of sling decrease the success. What's your experience for long-term?
So this is correct with the fixed slings. We see this problem because the sling is not fixed on the bone like the invents was. So it's only in the tissue, and if the muscle and all the tissue is getting weaker and weaker during the aging of the patient, it can come a little bit down. This can be a problem, and in addition, with the advanced sling, we had also the problem, but in the early beginning. It has nothing to do with long term, but in the early beginning. So this is why I recommend my patients to do like we do it, or like we do it in Munich with our female patients after surgery. We recommend to perform pelvic floor muscle training 5 minutes a day, still after surgery. You have the same problem with the TVT or TOT. There's no difference.
So you can you can improve the result if your patient after some years again exercise.
I recommend Don't
Always.
stop it.
Okay.
Don't stop it after surgery. 5 minutes a day are enough.
Last question, please.
Okay. Congratulations for your lecture. It was a good revision for us. And one question. Why do you think, in your opinion, the adjustable sling is better than fixed sling in the post-radiatory patient? You have more pressure,
Yeah.
and don't you have more risk of erosion in this case with more pressure?
You have more pressure, and very often after radiotherapy, all the tissue is really scarred and fixed. It's really difficult to mobilize everything. And for the fixed slings, especially the retrourethral slings, really have to mobilize everything, and it has to be really mobile for the good results. So I'm not afraid of erosion if you only increase the pressure by 10 to 15 centimeter water. If you go higher, I'm afraid, yes. And this is why you should stop readjustment at some point. If you readjust it several times and nothing happens, you should think about the concept and not readjust and readjust and readjust.
We are just in time. Thank you very much for your talk.
Thank you.
And